Alright guys, I have no idea how to start this video except by... It came! It finally came! The big one. Okay, you can see the name. You can see my name. You can't see the full name of the person. Oh shit, and I even repacked it like this. You're probably wondering what the fuck this is, but it is this booklet that I have been live streaming the past... Hey guys, just to let you know that I have a Patreon.
Nice.
If you are interested in supporting me, head on over to patreon.com and subscribe for some exclusive content. Like, I'd say the past, what could it be? I'd say a good past 2 months, 1 month and a half. It is in French. I'll try to translate as best as I can. The reason why I did it in French is because I plan on publishing this book. And so what it says is protocol and procedure for the intentions of respiratory therapist. It's the first edition, and it was written by myself. I'm a respiratory therapist. You've got the legend over here of how this book is supposed to work. Table of contents and so forth. So it's about, how many pages is it? So it's about, oh, there's no pages over here, but you got the abbreviations. 113, but about 115 pages or so and so. And as you can see, you already saw like a preview of the video and everything like that. It is available today on my Patreon. It is available for purchase. It is available in various links in the description. You're always gonna see it. You're always gonna see it in you're always gonna see it in descriptions and stuff like that. And I know you've always been seeing this over here, this first ever protocol. What's really cool about this is, let's say there's protocol on one page and description on a second page, 4 protocols that I find that are too big enough to fit on just only one page. And what's really cool is you just do this, have it with you, flip it over. It's pretty cool. That's why I decided to do this type of finishing. So it is, like I said, available on my Patreon. I'll try as much as I can to produce the links every single... I'll try to produce every single time the links, provide the links in the descriptions of everything like this. So as you can see, it's pretty much systematic. It's very, 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 very systematic in and of itself. And if we flip it over, you have the notes over here. And you have everything that's describing the instructions for over here, which is pretty amazing. Am I going to go into deep details of every single protocol? Probably not. I'm going to try. Really. The reason why I did this is mostly because I figured out, as you can see, these protocols fit in one page, as I was saying, compared to big protocols like these who take up like most of the page. You need another description over here. So the reason why I had done this, these protocols was simply because I thought that new grads in respiratory therapy here in Quebec were not sufficiently equipped per se in order to handle complex tasks. And this one, I honestly I wanted to do one of them for anesthesia. Unfortunately, I kind of figured out that anesthesia here for respiratory therapists in Quebec is kind of its own thing. So it's unfortunate, but I cannot, this is only this is the protocol book for general respiratory therapy, and unfortunately not for anesthesia. But I am also probably working on that because right now my specialty is currently an anesthesia respiratory therapist. I would like to just point out this protocol. I love this protocol over here. So endotracheal intubation protocol, you can, like I said, flip it like this. Take a look at it over here. And if we take an example on this protocol, you have the title over here. It's indication, you've got the notes. And it starts, this is your starting point. The client responds to the indications, so non-protected airway, unconsciousness, Glasgow less than 8, respiratory fatigue, circulatory instability, and failure of the basic oxygen treatments. These are just only but a few indications. There's probably many more, but I digress with me. I'll explain to you why this isn't like an official that it's supposed to be this way, but I'll take a small time in a few seconds to explain to you that. So you have the error here. It says note 1, 2, and 3. Prepare the medication. Anxiolytic, if needed, analgesic, a hypnotic, and a paralyzing agent. See section 7. Section 7 obviously being, so, and this is a little bit how the book also works. So if we are to go all the way to section 7, which is already, you can see the medication over here. Section 7, and they said prepare an anxiolytic. The only anxiolytic I have over here is Madaz, and they're all in alphabetical order. So Mannitol, Madaz, right? Then it says an analgesic. What are your analgesics? Well, again, they are in alphabetical order. Go to F, the one that's always taken is fentanyl, so fentanyl, there you go. You have fentanyl over here. They said after that a hypnotic. The hypnotic we usually use for intubation is propofol, right here. And finally, a paralyzing agent. So you got your Sux over here, and you finally have your rocuronium over here. There you go. So that's a little bit, when the book references you, as you can see over here, references a section, you go to that section. So, second note, observe saturation with a device already in place, venti mask 100%, or high flow BiPAP, high flow oxygen, or a BiPAP. If not, take in charge the breathing with a bad mask ventilation. Careful for reflux, for gastroesophageal reflux, if the patient has a full stomach. Refer to references 9.3 for difficult intubation criteria. And this is pretty cool. Why? Because if I were to go to reference 9.3, and you're already seeing a preview of this book, it's really full of wonderful content. I had these on stream once. We drew this together. We drew all of these together on stream, which is super amazing. I'm just gonna put the camera a little bit further. Hopefully that you guys can hear what I am saying. So yeah, as you can see, reference 9.3, criteria for a difficult intubation. You get your look, you get your evaluate, you get your lemon, and you get your boots. There you go, easy, very easy. Very organized, very nice, very demure, as a lot of people would say. So you've read all of this. You're clear to go. You go right down. So pre-ox with 100% O2 for 3 minutes. Try to aim for 98-100% of O2. If you cannot, and I think I wrote it here, if an SpO2 at 98 of a minimum of 98% is not attainable, Well, you try to get your best saturation. So if he's saturating at 95, well, you gotta go. You gotta go. Is he bradycardic before intubating? If yes, you give atropine, and this is based on the ITLS intubation algorithm protocol on the 8th edition. This is what they, if he's bradycardic, you give atropine. No. Give an order these medication. So the induction medication that was mentioned over here. Compression of the cricoid cartilage if needed, and try to intubate. Have you succeeded post 30 seconds? No, you go back here, keep preoxing, and then you restart your sequence. If you've not been able to after 2 attempts, this is your first attempt, then you go here. You only go here, and then you would start your difficult airway protocol. And you see you got your indication, which is failure of protocol 1.4.1, which is this guy over here, intubation of basic endotracheal. So this is how it works. This is how it works. You just follow everything over here. Have you succeeded? Yes. Well then, put the BVM on the endotracheal tube and verify the position of the tube. Auscultate 5 points. The CO2 curve, is it available on your screen? And the thorax has to rise, the chest rise as well. And you begin the ventilation into note 4, and you got your ventilatory parameters over here. Simple, very organized, very demure. And it just goes on like this. And the way I've separated this this algorithm booklet, as you can see here, you've got your non-invasive respiratory therapy stuff. So everything that's non-invasive, all the way up to intubation. Once that's done, once your patient is intubated, you've passed the vocal cords and he's intubated. Well, now you can get into your ventilatory assistance protocols. Ventilatory assistance protocol. So it's pretty easy. Chapter 2 is once he's intubated and ventilated, right? So here it is. And again, there's about 10 procedures in here. This is your ventilatory check. This one is in case that there's an acute exacerbation on the ventilator and you need to ventilate your patient manually with the bag mask, and then you can. These are your alarms, and if there is a leak in the system, adjustments of alarms. This is what happens if there's an increase of minute ventilation on the patient's side. This one is to manage auto PEEP, management of the endotracheal cuff, the recruitment maneuver when you are attempting to recruit the lungs, changing into a spontaneous breathing, extubation protocol, and you got all these 10 of them. And these ones, you also have the references of where they got adapted from. I mostly use pill beams. Because that's how. Give me a second. Let me take some water here. So, Pill Beams was probably the best book I've ever had in regards to ventilatory assistance. We get into medical protocols, and this one is fairly interesting. We got the asthma, status asthmaticus. We have cardiogenic pulmonary edema protocol. Management of burns. You also have, what's really interesting is ARDS management, anaphylaxis management, convulsions, management of convulsions, laryngospasm management of the adult, and finally sedation and pain management on ventilatory assistance. Anesthesia, here's the thing. Since I'm an anesthesia RT, we do have we are allowed to give medication regarding to pain. Unfortunately, as an RT, regular RT, ICU RT, basically, you don't really have such protocol, so you don't know where to go. So this is probably in terms of helping the RT knowing, okay, what can I give parentally, right? And again, you've got the explanations over here. Unfortunately, this doesn't fit into one page, so everything fits into a single page over here. Clinical approaches. These are more like generic stuff in the hopes of letting the RT guide themselves to a clinical intuition of what the patient may have. It's not necessarily diagnosing things, because I do mention at the beginning of the book that this is mostly to help clinical judgment and not as means of diagnosing anything else. This is based out of the ITLS. This is the evaluation of a polytraumatic patient. You then have the protocol algorithm for PFT. So basically, you do a PFT to a patient, and this one I really have to like zoom in. Sorry about that. So is my FEV1 inferior than the limit of the normal? Yes, no. Is my vital capacity greater than the limit inferior of the normal? Yes. Is it normal? DLCO normal? Well then, he might have these anomalies. And you arrive at you kind of just end up arriving at what the patient may have, and what kind of treatments would be needed for this kind of patient in front of you, you know. So is it a resistive issue? Is it more of a compliance issue, right? This one over here is one that I don't think a lot of people will agree on me with. This was taken from Rosen's Emergency Medicine. I think it was the 4th or 5th edition. I think they're at the 4th edition now, or 3rd edition. I don't remember. But anyways, Rosen says if your patient is cyanotic, is the O2 supplement that he's receiving working? Is it working? Yes or no? Well, then you still need to do a chest X-ray. Advise medical superior authority for a chest X-ray. So the doctor in this case, or the nurse practitioner, or the PA, or whatever. And then you go out through this algorithm, and then you just kind of figure out, okay, well, he may have infiltrates, he may have an infection and whatnot, and you kind of get to these like conclusions. And whatnot. I think, again, this is a first edition, and what I was trying to say earlier, what I was trying to get to in a few seconds, is that, you know, this is not guidelines necessarily, like guidelines in terms of this is the final word, this is what's supposed to be respected. It's more taken to interpretation in order to help newer RTs better understand what's black, what's white, and then once that's understood, they can start playing in between the lines, confirming or infirming what this protocol book says, and what other healthcare professionals think and their thought process of thinking, so that you develop your own skills, you know. This one is the protocol to determining shocks. So cardiogenic shock, hypovolemic shock, anaphylactic shock, neurogenic shock. So it's determining where you're, like what type of shock it is, and in terms of helping you identify it. Pediatrics, I was thinking and hinting of making like a specific pediatric, but I'm not a pediatric specialist, nor do I work in pediatrics. But I figure out as an RT, you do get to do some neonatal resuscitation eventually at the hospital that RTs may be working at. I need to take another sip. It's a quick book. It's an easy read once you understand what you're doing, what the thought process is in terms of determining this book. NRP algorithm, as usual. Suction algorithm for children, as usual. non-invasive ventilation, and then you have invasive ventilation. So 2 separate protocols for the children in respiratory distress. VHFO initiation for neonates. Weaning of non-invasive ventilation. You get a bronchiolitis algorithm, and I do have to say thank you for St. Justine to have provided like a general protocol on how to handle this type of stuff. And finally, the taken in charge of asthma, and we also have the pediatric assessment test somewhere around here. So the PRAM score somewhere, and I'm saying somewhere. PRAM score is somewhere in here. There it is. The PRAM score. Taking charge of asthmatic children based on the PRAM score. And this is what you got. Moving on. ACLS protocols. Pretty self-explanatory. Somebody's in cardiac arrest. Somebody is tachycardic, about to go into cardiac arrest. Somebody is bradycardic, about to go into cardiac arrest. Post-cardiac arrest algorithms, everything is in section 6. That is how it got separated, and you even got like all of these protocols as well. As you can see, there's just missing the PALS, so the pediatric advanced life support algorithms. It's just missing that. Like I said, this isn't a pediatric it's not a pediatric algorithm book per se, so that is what it is. Moving on, medication. You got, and I tried doing various streams on medication, and I think those were like the most boring streams that I've ever done, so most of them I've never actually published them, but that's because at some point I was like, wait a minute, I am working too much on medication. This is not a compendium of all of the medications that are available. This is mostly like a reference guide of what it's supposed to be. So as you can see, I narrowed it down to medication that general RTs in the ICU, at the emergency, or just on the floors that they'll probably encounter. You got mostly have all of these all the way in alphabetical order, named by their generic name. So that's pretty much it. You get to section 8, normalized procedure. My favorite one, I think, has to be this out of section 8. Evaluation of the cardiorespiratory evaluation. Now, here's the thing. My board here in Quebec defines RTs being cardiopulmonary specialists, and not technicians, specialists. And so what's interesting here is that I've also added in auscultation, cardiac auscultation. So just the B1 and B2, we're not cardiologists, we're not nothing like that, but we are able to listen, since the pulmonary system and the cardiovascular system are kind of intertwined, like it or not. It's still important to listen to, I find as a respiratory therapist, to listen to the sound of the heart to know if everything's normal. And you've got everything structured. So preparation, inspection, palpation, percussion, and auscultation. And it also doubles as what you write in your chart when you're charting. You follow this sequence, you chart what you found in this sequence. You got the X-ray. Also, this is also one of my favorite ones. Steps for analyzing X-ray. You got RPPI is a percussive, the percussion thing, right? So the percussion thing. Then you got, this one is the percussion. The RPPI is the, oh my god, what was RPPI for? It's French. It's something in French. But anyway, I think it's a cuff assist. I actually genuinely think it's the machine that is the cuff assist. Respiratory re-education. You've got some instructions over here. Spirometry. spirometry in conjunction with the protocol, with your protocol, which is 4.2 in the 4.2 section, the one for the PFT algorithm. Aspiration techniques, so tracheal and nasopharyngeal. And then we finally get to the references. It's a pretty big algorithm booklet per se. There's about 115 pages, as you may have saw, but they're all pretty useful, I find, and they all intertwine. So you can see you got references for your Milan patty. We, like I said, we worked on this very fine. Criteria for a difficult intubation questionnaire for the patient. I didn't use the sample OPQRST like all of the other nurses do. I think that AM chloride AA works just as fine, and you'll see it very, very well. If I were to explain it, allergies, do you take any allergies, medication over the counter and by prescription, types of dyspnea that you may have, history, type of cough if you present with cough, history taking, past medical history, or are your immunizations up to date? Do you have any history of surgeries? The location where the pain is, the last meal, the onset, the radiations, presence or not, intensity, and this is one of the algorithms that, the questionnaire that I like, because it regroups everything from OPQRST and the sample as well together. A transfer of information, MyStat. This is what the military uses to transfer medical information to other patients. Traumatic. This is a rapid trauma survey. It is the rapid trauma survey that I've added in here. That is in conjunction with the protocol, the evaluation of the polytraumatized patient. Gold, CRM scale, the asthma classification according to the FEV1. The conscience, so AVP, I do mention a lot of AVPU, and the AVPU, I swear to God, is probably one of the most useful scales ever, because it's a fast and reliable scale that skips the RAS, and it skips the Ramsey sedation scale, depending on what your hospital uses. So if your patient is unconscious, you know that he's unconscious. You can just say unconscious, right? You're in your AVPU. Anyways, and then you got your Glasgow Scoma scale. You got your capnography, the CO2 capnography, and what it means over here, which is pretty long. You got your lab values for references for RTs, hemodynamic values, arterial oxygenation values. And these are like your formulas, your RT formulas that have probably never been used, but probably are efficient to know. Hemodynamic formulas, spirometry formulas, common problems of patients on ventilatory, on mechanical ventilation, and complications of non-invasive ventilation. Types of asynchronies, courtesy of Hamilton, APGAR scale, Silverman scale, and this is also pediatric references, PRAM score, anaphylaxis, and probably this is one of my favorite ones. This one is a mini poster that I had done on an 8.5 by 11, but I never ended up using it. Because I'm like, okay, well, there's so much inhalation medication. If I need to reference it post when I'm doing charting, and I did 2 to 3, 4 patients, and I don't remember what medication they were, let's say the second patient was taken, I can easily refer here and go like, oh, okay, well, it was a combination of medication. Which one was it? And just go through the names and be like, okay, well, it's this one. Definitely she's taking this one, and I can confirm also with, and I can also double check in the chart, in the patient's chart, if the doctor gave the correct dosage to that patient, right? I can easily just go here and say, does the dosage make sense? And then finally, these are abbreviation, and the book ends here. With that being said, we've powered through it. If by any chance, I will probably be doing another, probably streams about how and why my thought process was when creating some of these algorithms. But all these algorithms are referenced by professional textbooks, right? That I've taken the time and effort to compile them together for the use of respiratory therapists. Anyways, thank you so much for watching this. I have been your host, AJP, respiratory therapist as well. If you enjoyed this product placement video, whatnot whatsoever, hit the like, subscribe, share button, and I'll see you folks next time. Thank you.
Hey guys, thank you very much for watching the whole content. I hope you enjoyed it. If you want to catch it live, come on twitch.tv/MajinP, that's MAJINNP. I appreciate the support this channel has been getting, which is making it growing bigger and bigger. So please take the time to like, subscribe, and share, and all that fun stuff. I'm always here trying to get up there, so if you want to support your boy, you know what to do. Thank you very much again for watching, and peace out.